So, continuing on. The next speaker, I also know well, Dr. Sam Lamb. So, Sam is one of the leaders in fat grafting, and I think he brings a unique perspective in not only being a surgeon, but encompassing a unique metaphysical understanding of what he does and what he brings to his patient population. So Sam, as expected, his talk would be fat transfer simplified, because that's what Sam does best. It's make complex things simple. Okay.
Thank you, Neil. I have no disclosures. I give my book royalties away to charity, so I don't have to deal with any disclosures. Volume is a critical component of aging. I think that it is one element, though, in the entire picture. And I think that if you try to look at volume as the only method of improving the face, you're going to over-volumize a face. There is gravity. There are other components as well. What I want to do in this lecture is walk you through the mental process, the philosophical perspective of fat, and then go through the nuts and bolts of how to do it, because clearly I think that is a prime interest. The first lesson, I'm going to break it down to 9 lessons here of things that I want you to know in terms of limitations of fat. Fat is truly bioactive. It's not Restylane or a hyaluronic acid being placed. It is, if you gain weight, it'll be a problem. So where I'm very concerned about it is to use fat in a very young individual that has not been metabolically stable, let's say a teenager. Or a 20-some-year-old wanting a little bit of treatment. In that case, they usually don't need fat. I mean, a little bit of fillers would be awesome. So be very, very cautious of using this like a stuffing, okay? It's not a stuffing, it actually is bioactive. So that's an important lesson. Also, I see people use this in a reconstructive capacity, trying to fill mandibular defects, etc. I would encourage you to use fillers or something else. I mean, fat is something that's problematic. If someone's more mature, their weight is relatively stable, and you want to do that, I think it's okay. And also, I see people try to use it as a filler for like dermal acne scars and things like that. I think it's problematic. Those things can become a problem 5 or 10 years down the line. I've been doing this about 12 or 13 years now, and I've been seeing that. The other lie is that fat is temporary. I mean, there is a variable resorption, I agree with that, but I do a lot of lip corrections, and you know, this is a very gross slide, but I opened up a lip and I looked in there and I saw fat lobules. I said, "You had fat grafting?" She said, "No, oh yeah, I did." And so this is 10 years later. So fat, the part that persists, is there. It is unquestionably there. It is not scar tissue, it is there. And I've seen when patients gain a lot of weight, there's problems. So it's something that I want you to understand. The other thing you see all over the internet is that fat grafting is difficult in the lower eyelids and you're going to have problems. I've never had a problem with it, even from, I mean, you have a rare case of a little bit of a small bump, but I can tell you that if you do this right, from my very first case till now, I have not had issues. It's very, very, very safe if you do it, and I'm going to walk you through how to do it. So technique is everything. Also with this is that, you know, nowadays you can add hyaluronic acid and do the same technique in the OR as you would for fat. Now I don't use that technique in the office, but if you're in surgery and you're saying, hey, I'm really scared to do fat, try hyaluronic acid, maybe at a discounted rate if you haven't done it before, and try to do that. This is one of the big lessons I've learned over the last few years is the anterior cheek. You know, people say fat really retains well in the anterior cheek, and the answer is absolutely it does, and that's a problem. This is a dynamic issue, and I've slowly receded away from the anterior cheek. When I was, you know, 7, 8 years ago when I was doing fat in the cheek, I was putting only like 1 or 2 cc's, and I'm looking at my patients long term and they look slightly overfilled in the anterior cheek. And the other extension in the last year, so I haven't presented this concept, but I really see the anterior cheek being an extension all the way to the buccal zone. So when you even get to the buccal area, I think that's problematic. So I would put, honestly, it sounds crazy, nothing in the anterior face of the anterior cheek or in the buccal zone with fat. I think it's problematic. And when you start to put fat in the lateral aspect of the face, you'll see better outcomes. And I encourage you to hear some of my more refined thinking in terms of halos and shapes and things like that in the next few days. I have a video, about a 20-minute video of my injection technique for fillers. I think it's tomorrow. Also cut the voodoo. There's a lot of these terms like stem cell facelift, you need to put PRP in, things like that. There's no question that over time, looking at fat transplanted zones, there is a improved textural component to the skin. But I just don't try to sell that because it's so variable and it's so subtle and it takes so long for me to see that outcome that these are just marketing terms, I think, that confuse patients and over-promise things. I'm a single session guy. I think that of course, if you're a person that injects a lot, and do multiple sessions, it's fine. I believe that the problem with that is that, as I said, fat is bioactive. You can overfill someone. You can overshoot the result, and that's problematic. So what I do is I touch it up with the little fillers in the office, somewhere at about a year or 6 months, 9 months, maybe a small amount, because fat is never perfect. But it really delivers. It's never consistently 80%, but enough of the patient says, wow, this is awesome. And so fillers for me is that little touch-up. And the way I look at my practice, I love Apple design, and so I always say that one is about design and also is about controlling the end-to-end experience. So if you're a surgeon doing the surgery and you leave your fillers and Botox to someone else, potentially you need to fine-tune the surgery. First of all, no one wants to have surgery every year, so you need to maintain it from these big peaks and troughs of big surgery. So I control the experience by doing the little fillers, and I'm passionate about it. So if you're not passionate about it, obviously give it to someone else, but I believe that today, with the advances in office-based techniques, you can do great surgery and great fillers as well. And I think that's the other lesson, is that fat can't solve everything, okay? Fat is not good to try to fix surface flaws. It's really hard to do that. Fat is a soft, you just feel fat, it's soft. It gives a very beautiful foundation or mattress to the face, using this analogy, but it doesn't fix all the flaws. So, I think in many respects, fillers have dominated my practice now over fat. So I may be doing, if I do a facelift or a rhinoplasty, I do fat, but I do fewer and fewer standalone fat graft cases because now for people, especially in their younger age, I wind up just doing fillers. Since October 2010, the advent of the microcannula has really revolutionized my practice. And so that a lot of talks I'll be giving is on that. So it's just basically a refinement of the instrument that you use in the OR is the microcannula. So I'm going to talk a little about philosophy, and then I'm going to get down to the nuts and bolts of this. So I like replaces like. And what does that mean? It means you replace soft tissue for soft tissue and hard tissue for hard tissue. Now you could say, well, how does aging occur? Well, we do lose hard tissue, but I believe we lose a proportionate higher degree of soft tissue. So if you look at this in a schematic format, there is a relative exposure of hard tissue, and if you put an implant in, physical implants, except for a chin implant where someone's got microgenia, you can't fat graft someone's chin. But you actually get more exposure. So if you go back to that model of aging and then you add fat or some soft tissue augmentation, you replicate that same degree of what they had in youth. So the blink effect is, what I ask of all my colleagues is to look if someone not only just has a straighter jawline or a fuller cheek or a fuller eye, but do they look more attractive? Using your right brain, and that's really a good challenge for you, is constantly reanalyze your results to look at that. The shape of the face is so important, and when we start to become lower dominant, we definitely need a face or neck lift, but there's this shaping that is ideal. And what is the ideal? If you ask most women when they thought they looked the best, they most often won't tell you at 20 because they're too full. And if you think of what baby fat is, all it is fat defined prior to the age that you liked it. So it's just this, a 5-year-old has more fat than a 10-year-old, has more fat than a 15-year-old, has more fat than a 20-year-old, etc. And so this amalgam, this shaping change is really more of an oval shape that is there. So if you focus more on the outer face, so we're moving our elements from the frontal face to the side face, the outer face is so important. And that's a critical zone, is looking at the shaping of the face around the edges of the face, of course around the eyes too, but if we can start shaping a face to be more attractive, I think we can get a person to look better. And so that's just taking that outer scalloping of the face and improving it. Now this is an older photo, some of these definitely can be touched up with a little facelift and rhinoplasty as well, just to improve, overall with the laser as well, also with the blepharoplasty, facelift, rhinoplasty, just to improve overall all the components. And light is important. We oftentimes look at light, I think, incorrectly. We try to use flash photography in the photography room, and I think that we're really dealing with a top-down lighting. And when we're dealing with top-down lighting, if you think about the deflationary model, it makes shadows exaggerated. So when I take photography, the way I take my photographs are always with no flash photography. You can't see the shadows as well with flash. The way you do is you just shrink down your photography room and use a lot of overhead lights. If you use very few overhead lights in a very large room, you're going to get too much shadow. So you have to play with that. So what I like to try to do to see my results and really see it in a realistic fashion, the way that someone would see that person in, like, let's say, sitting across from the dinner table, is replicate top-down lighting without over-exaggerating that. The other question is longevity. How do I see fat change over a period of time? Because it does change. And I think a lot of people that are overzealous in placing fat are not taking their time to evaluate their results over a long haul. And it also, I do a lot of hair restoration. That's going to be my talk at 10 o'clock. Hopefully the room will clear out at that point. But it really, what I'm going to talk about with hair, just to let you know, at 10 o'clock is really, or is it, yeah, 10 o'clock, is more just sort of the trends going on today. And there are some trends that are non-surgical as well. I think your patients need to know that information, by the way, as a quick aside. So really over time, fat is a graft. It is a free graft that has no attached blood supply, and there's a maturation of that graft over a period of time. So if you look at it as bioinert, you stuff it in and it goes away, it's not right. And so if you think about a hair model where hair begins to go through a neovascularization process, you can see this with fat. I don't think it's just that stem cell effect, although of course adipocytes are very rich in that. It's an evolution of change. So the way I try to teach my patients is you're going to initially hate it. You're going to think, man, I look too full. And then there's this lie. It's this perfect period of time between 2 to 6 weeks where everything looks just too good. And that's because all the wrinkles are gone, the pores are perfect, the fat has not been partially resorbed. And then there's this dip process. And then if you watch that fat over time, don't stick fillers in there, don't do other treatments and follow that result, you're going to see this maturation process. And I always tell my patients, it's most likely never as good as when it was perfect, okay? Because there's going to be some absorption. But you should almost always be better than your baseline, where you just look better. And I believe that with fat, the more shadows that you can manage, and again, this talk is, I can't go through all the shadow, my thinking the last 2 years of evolution of thinking of how I see shadows and halos and triangles and all that. So I really encourage you to see my upcoming talks in the next few days up through Saturday if you're still here, just to really sort of understanding how I embrace shadows and light today. But the point of this is that you have to really deliver good communication with patients. If you don't do good communication, you really fail miserably, because you can have a great result and the patient can't see it. So initially it's going to look too full, it's going to look perfect, and handhold the patient through a process where it's going to go down a little bit before it gets better. So that's very important. So initially swollen, too full. And if you just watch over a period of about a year, there is a gradual evolution of the face. And it's important to follow that change over a period of time. You don't just look at it in one shot. And the only thing I did for her was ongoing botulinum toxin. But that's important, to watch your results over time. As much as you watch your rhinoplasty or facelift result, also watch your fat grafting results over a period of time. Donor dominance is a concept in hair restoration, which means taking hair from the back of the head, moving it to the foreground, and it retains the genetic characteristics of the hair on the donor site. In other words, it's not programmed for loss. I think the same thing applies to fat, because you're taking a free graft from another part, moving it somewhere else. It is going to have a higher predilection toward weight gain. So this is why I'm really careful. I reiterate points both to you and to my patients multiple times, because it's hard to remember all these things. Because fat is bioactive, it has donor characteristics of the area where it's harvested. If you say, well, then where do you harvest? I love the fat where it's well retained, in the areas of higher estrogen, high volume in the belly or abdomen and the thighs. But it is something you need to be careful with and not overfill. So that's an important lesson, is don't stuff them and hope that it goes down, because you don't want to do that. How much should I use? That's of course what I'm going to talk about. So I don't know if I really want to improve take. One of the questions I get oftentimes after these lectures is, how can you improve take? What have you done? And I said, look, you know what? I don't necessarily want to improve take. I think it's risky. Okay, how do you do it? Nuts and bolts, 101, basic, walk through this. So all this in the book, but I'll tell you that the book is written a decade ago, so it's outdated in terms of a lot of philosophy and volume numbers, but the methodology is intact. So in terms of just the basics of how I approach the face mechanically, it's not changed over that period of time. So you draw all these little lines, everything, but then you want to always. What I do, I'm going to go back one. What I do is I think through the face when the patient's sitting up. I have a photo in the OR, which I'll show you in a second, but I think through the face before I start the process. Harvesting, for those people that don't do body work, you really in the medial thigh, you just need to go through a little bit of a septum and make sure you're not seeing these reverberations through the skin to be safe, so you don't get a contour deformity, and really fan out carefully. It's all covered in the book. So this is basic instrumentation for fat grafting. I have no financial affiliation with any of the companies here. I use the tulip system. I actually harvest with the old Coleman method, the harvesting cannula with the bullet tip. So you just harvest. I use this little Johnny lock, that little lock back there. It saves my hand a little bit of holding the negative pressure, pull up about 10 cc's. By the way, I don't use lidocaine. I prefer to do this under general anesthesia if I can. I find that with a lot of tumescence that I get architectural changes to the fat and I get some loss of the fat volume where I see a much higher hold rate when I don't adulterate the fat with either tumescence or lidocaine. So this is philosophy that's there. I mean, you can do however method you do, but I believe in my hands this works well. Just take off the bottom portion and then put on that little cap, pull off the top, and then put on the cap, and you're just going to centrifuge balance. I do 3,000 RPM for 3 minutes, but this is a lot of rain dancing, voodoo witch doctor stuff again. I think there's so many ways to do it. Find a physician or a surgeon that has done great work and you like their work and you find that they have longevity, and replicate it. Because I think that this is all the simple mechanics that are not that difficult. And if you hear something like, I trained with a doctor in Japan many years ago who washes his fat. Great results, showing great longevity over 5, 10, 15 years. Even despite ongoing aging. So this is not the gospel way to do it, but do it sterilely, cleanly, take it out after it's been centrifuged. You're going to see the supernatant, infranatant. Obviously, just pour out the supernatant first, and then dispense with the infranatant after that. I don't necessarily wick these. Sometimes you get little cotton fibers. Having a little oil there is not going to screw things up. So this is an older method. But then I just go and transfer it into a 25 cc syringe. Make sure you don't squirt the fat across the room by letting the fat column slide down. Fill it up to the hub, and then just use a female-to-female transfer hub and transfer from the 1 cc syringes. I use, so this is just showing you the photo in the room. I have the photo in the room because it's a good thing just to always look back and see the facial shape in case you forgot a few things. The cannulas I use 2 cannulas. I don't have any, they don't pay me for this comment. I just use it because people are going to ask me, what do you use? I use the 1.2 millimeter for everything. I use the 0.9s on top. A colleague of mine loves the 0.9. I love the 1.2. It doesn't really matter. I think that I just find the 0.9 is, you can already see it's a little bending a little bit. Maybe I'm more not as gentle as my technique. But there are a lot of fibrous adhesions. I find it much easier to use a 1.2 to release things. So people ask what planes, and as I walk through the mechanics of the face, I'm going to allude to some of these areas. It is not so difficult. Don't make this rocket science, okay? Essentially what you're dealing with is just basically a lot of things is just in the subcutaneous plane of least resistance. The only area where I think the plane absolutely is critical is in the lower eyelid. And we're going to spend a few minutes and discuss that in detail so that you don't get into problems. I'm a faculty with a colleague of mine in St. Louis for a face course that I actually teach injecting lower eyelids with Vaseline and a cadaver model. And it actually it's so easy. When you feel release of this orbital septum along the arcus marginalis, once you feel that release, you know you're in the right plane. And that's the trick here. So the lower eyelid is what I start with first. I'm standing next to the patient. For most of what I do, I'm sitting. I do a lot of Asian blepharoplasty. I'm going to give a talk on that tomorrow. Sorry, giving plugs for my talks. But and so with that, I think symmetrically. So I'm always working a little bit here on one side, then both sides. So I'm working back and forth. I do a brow on one side, brow the other side, and I'm constantly developing the face as I go. I don't like doing one side and then doing the other side. Also keeps my memory exactly how much did I put in. How did I deliver it? Why did I think this? So it's much more immediate feedbacks by constantly going lower eyelid, upper eyelid, etc. So the lower eyelid, I'm filling about 1 to 2 cc's in the medial aspect, and then 1 to 2 cc's in the lateral aspect, and then a little bit in the lateral canthus, which you'll see in an upcoming slide in a second. you don't want to overfill the lower eyelids, and that's very important. I've had some of my colleagues, very experienced, say, I go up right to the ciliary margin and try to fill up near the eyelid. I would really caution you against that. The skin is too thin. Again, the fat is bioactive. Don't get near the skin, near the lower eyelid. Just stay around the level of the orbital rim, and that's important. So, I divide it mentally into a medial, a lateral rim, as well as the lateral canthus. And the reason I do that, it just keeps my numbers solid. It makes me have better access points. So I think of the lower eyelid sort of like a semicircle. So it doesn't matter how many entry points you have. The entry points are just tools to get to where you want to go. So I usually typically make 3 entry sites, and one is hitting the medial, and then I want to go perpendicular. So I'm just facing perpendicular. I go one toward the lateral portion, and then another one toward the lateral canthus. And I'm just placing, again, about 1.5, 2 cc's per medial to lateral. So total in the lower eyelids, probably no more than 3 to 4 cc's, all placed deep, which you'll see in just a second what I'm talking about here. So this is not I don't think this is the video. I think the next one's video. Yeah, here we go. So this is just showing you how I do it. It's very simple. Your fingers, your non-dominant finger is feeling the tactile feedback, and it is just dancing back and forth across the orbital rim. You've got to feel this sort of arcus release as you're going across it. If you are just sticking it in there, you can easily fill it on one side or the other side, orbital septum, and cause an issue where it can be lumpy or visible, or actually worsen the trough. So make sure you're feeling that give. If you don't feel that little give, your problem. It's not, I heard people say, is it subperiosteal? I don't know how the heck you can get this subperiosteal. It's supraperiosteal, submuscular, just little aliquots. And if you get stuck, your fat gets cloggy, take it out, inject it in the air, and then put it back in. So this is an area where I'm putting little passes, a 50th of a cc, and it takes me a full 10 minutes to do this. This is the time that I'm really slow, very concentrated. I'm standing next to the patient, and to access the left eyelid on the contralateral side, I'm also standing on the patient's right side, accessing both. So that's an easy way to access it. The lateral canthus is important. The first couple years I was doing this, I was like, I get enough just by filling lateral medial. No, you need to go and separately. What I do is I sit down, I hit perpendicular to that lateral canthus, and I put in about a 0.5 cc to a cc just to fill that little lateral divot, or you're going to see a lateral divot there. And the more that I think about the eye, and again, some of this maturation process is through fillers. And it's funny, it's just like developments in the iPad inform the iPhone develops the iPad. Same thing here. The more I think about how I see patients in the office, it develops how I see patients in the OR. So just putting it in the nasojugal groove, I don't really do a lot of that anymore. I think I'm moving away from just filling for the sake of filling in every area. I really am, the nasojugal groove, I don't think you need to fill too much in this area. I actually don't fill anything here much anymore. The brow, again, I'm not going to go into really all the details of how I think about the brow, but I've really focused on the medial brow now, and I think that the medial brow is critical. This is where the A-frame deformity is. And even a little bit of exposure of that medial fat pad, if you can just sort of arc that fat going right lateral to that area in that A-frame deformity, you can really create a beautiful shaped brow. So I'm less focused on the lateral brow, more focused on the medial brow. And in the past, I was more focused on the lateral brow and less focused on the medial brow. Again, some of those subtleties, I encourage you to listen to my talks coming up. I just can't cover everything in 30 minutes. But I put in about 1 or 2 cc's, and I'm just filling over on top of the rim and then dipping down below the rim. So it's just over that arc from the upper eyelid brow is one unit for me. It's one confluence. It's just trying to take that bone edge, that inferior bone edge, and minimizing it. Don't overfill this. If anything, if you're new to fat grafting, just be conservative. Take all the numbers I gave you and go in the lower end of that range, and then see what you have. You can always touch it up with a filler if need be. You don't want to stick too much fat in, so don't overfill. The anterior cheek, if you're going to do it, which I encourage you, as I said, not to do anymore, you've got to approach it from this angle to release the malar ligament. How much I put in now, I rarely put anything. I put almost zero. The lateral cheek, I love the lateral cheek. I put a lot in the lateral cheek. I don't put a lot in there if I'm doing a facelift. It's going to be in my way, so I usually just look at the lateral volumization I get from lifting the face. But if I'm doing a standalone fat grafting, I'm doing a lot of fat in the lateral recess over the zygomatic arch, in the lateral subzygomatic region, really in the lateral face. I'm a lateral face person. I'm really focused on that outer shaping of the face. And the buccal zone, I already told you too. I'm doing less and less in the buccal area. Sometimes I'll put nothing in. If they have a very exaggerated buccal hollow, I will put maybe 2 or 3 cc's in per side. But I'm being very, very cautious because I'm really thinking, as I was alluding to earlier, that this is an extension of the central anterior cheek where there's a dynamic component as it migrates up during a smile. And then just this whole area, as I was mentioning, this is to me a lateral extension of what I was talking about with the lateral cheek. It's just this whole lateral expanse of the face that I fill. This is an area that where people start to lose some of the dentition. I can fill a little bit there, but I'm doing less and less of that over time. The pre-jowl, I love filling it. I think it's a great area to fill. You don't want to overfill it, but because otherwise you get too much in the zone. It's definitely not going to compensate for microgenia. But you want to fill it along the anterior recess, but also along the anterior chin. And if you get a little bulginess in this area, it will soften out. So because the mucosa is thin in this area, and I just fill along that zone. If someone's had a facelift and they get that loss of some volume here, sometimes there's an over-skeletonization based on the facelift technique. I just put a little bit in the lateral mandible. The key with this is I always go back and look at the anterior face. You'll hear this in my talk tomorrow. I look back at the anterior face. In other words, I stand in front of the patient and look down at the face to make sure this doesn't bulge out. Because if you're like a surgical mentality, you're always looking laterally from a lateral perspective, you can overfill a patient, and that frontal view is the key thing you're looking for. A lot of times we look at side views and three-quarter views, but look at the frontal view. When you look at your results, spend time to look at your frontal view. That's how people see each other. That's the most critical view that's there. And when you're doing volume, to me, it's the most critical view of looking at it. So this is just looking at it from 3 different directions. I don't put a lot in here. This is probably 1, 2, 3, or 4 cc's at most in the zone. And then the nasal labial groove, I just put a little in the canine. I'm really focused on the canine more than the inferior aspect of this. I think this is an area where we lose volume, that if we put a little bit in that area, even when I do fillers, it just makes a really nice change to the face in that zone. And this is just showing the inferior aspect of it. So patients, I don't use bandages, I don't use drains, I don't use anything like that. This is obviously all incisionless. So patients really don't like themselves that first week, and I usually tell my patients the first 10 days you're not going to like it. So it's important that you communicate to patients how much they're going to not like you for that first week. I even have on my website some videos on psychology. You're welcome to copy those videos, but it's important that patients realize, especially anything in the periorbital region, they don't recognize themselves. You know, it's worse than almost a facelift for me, is that area around the eyes is identity. And when that identity is mitigated or minimized over a period of a week, it's a real problem to have that. Encourage you, if you, I don't make any money on this either, so there are no disclosures. If you come to my workshop in late November, it's all hands-on for hair. Hope you stay around to listen to my 10 o'clock lecture. I really encourage you, as you think and process your results, to always think in an artistic fashion. And I thank you for your attention.